Night shift was close to about smoking 2 packs of cigarettes a day.
Yeah. It was in nurses. It was a 5-year study in nurses, that did 12-hour night shifts.
Little do they know they're chemically castrating the dude. And
exactly,
and then he feels worse.
If your sleep is not right, like, ain't nothing right.
Yep.
If your sleep,
bottom of the pyramid in terms of health and
you can't out exercise bad sleep. You can't. I mean, you're not going to overcome it.
Every mummy they've ever dug up from 5,000 years ago, literally, that has soft tissues preserved, they all had atherosclerosis. He's got huge cankles, and you're like, look, I need to put this guy on some Lasix. In the last 2 years, 3 of my physician colleagues have had MIs.
All right, well, back with Dr. Winge, and today we're going to try and just hit cardiovascular disease and testosterone. I've talked with Dr. Winge in the past about anabolics and their effect on the heart, but that was kind of more of a anabolic focus, TRT plus focus. Really, this is going to hone in on just testosterone, the normal guy running normal, appropriately managed testosterone therapy, and how to, one, maximize your heart health, get the most out of it, and stay functional well into your 80s and 90s. Mm-hmm. Dr. Winge has a great position in view as both family practice and emergency medicine trained, and constantly puts out good information, and it really hones in on heart health, heart prevention. Is probably the only person in the planet that I could listen to talk about Nebivolol for 90 minutes and stay engaged. And so
you need to get out more, buddy. You need to get out more.
No, it was just so good. I just kept going. I was trimming trees while I was doing it and was like, oh my gosh, this is already done. It's been 90 minutes. So I appreciate you coming on. Thanks for coming back. And then
my pleasure. Always my pleasure.
And then I got Coulter.
Especially heart health. Talking about heart health is near and dear to me.
Good. So. I'm excited. We have a lot to break down, and I think it's going to be an easy chat just between all of us. Coulter Salmon is also joining. He's a nurse practitioner with Live Oak and has a specific cardiology experience for 5 years, and also functional med background and hormone optimization focus. So he has a unique view and has a little bit different views in some things, so that I'm not just talking into the echo chamber with everything. I guess I'm just going to start and get the first question out of the way of, like, is testosterone cardioprotective? Is it good for the heart? Is it neutral? Or what do you think testosterone itself has a role in heart health?
Yeah, absolutely. I mean, I don't think there's any doubt at this point with the amount of data that we have. Absolutely. So men who have low testosterone, especially when they're in the true hypogonadal range, if you look at it's not just all-cause mortality, but if you look at specific cardiac-related morbidity and mortality, they are way worse off than men who have normal testosterone levels. So you see more atherosclerosis, you see more heart failure, and that's both kinds of heart failure with reduced EF and heart failure with preserved EF. We don't need to go into the differences there, but there's definitely worsening or increased rates of heart failure with men who are hypogonadal. So across the spectrum, you tend to see more problems from a cardiac standpoint in men with low testosterone than you do in men with higher or even just normal range testosterone. So, which isn't surprising. I mean, this is like a fundamental hormone for men and women. It's preserved across like almost all animal species. This is something that's been created by evolution or by God, depending on what your beliefs are. That is important for basically every higher organism on the planet. So it's not a hormone that's exclusive to, muscle and sex drive, which is what the stereotype is. This is a systemic hormone that there are androgen receptors in virtually every tissue in your body. So it's kind of important. You can say the same thing about estradiol, because those need to be linked together because they're obviously very closely related. But yeah, it's absolutely. So to answer your question, this is a no-brainer. Having healthy, robust testosterone levels throughout life is definitely associated with less cardiovascular disease, less cardiovascular problems as you age.
Yeah, and even whenever I even started the clinic, I still was having to defend that testosterone is cardioprotective and beneficial to these guys. The studies in like 2010, these poor studies in these older guys, I think it was 2010 or so, where it got the black box warning that it was negative for heart health and everything. And then I mean, I think we're doing the Traverse study helped kind of undo that, but we're still undoing it some. You still have people, who are scared of it, and man, but you just kind of see, even like you said, the heart failure patients, you put them on it and they have better exercise tolerance, their walk distances improve and everything.
Exactly. Yep.
Um,
Yeah, they do much better. They do much better. Now, if they're on a poorly designed program, of course, like they are not going to do well. But again, we're talking about properly managed, properly supervised hormone replacement by a provider who knows what he's doing. And in those cases, yeah, I mean, the patients do. We've all three of us have seen that. It's kind of a no-brainer. The Traverse trial definitely helped. It definitely quieted down some of the noise. It didn't answer all the questions. I mean, if I had had an unlimited budget, I would have done some things with that study to to make it even better. But it's as good as we're going to get. We're never going to get another Traverse trial.
nope, that's exactly
The
right.
drug companies and industry in general, and then the government and NIH and all these people that fund studies, they're not going to fork out more money to do a bigger, better Traverse. This is what we got, so we just have to use what we have.
Yeah, and it definitely has some limitations.
Sure.
One, I don't use androgel at all, and so like I wish we could do it, but I'm even. The thing is, you almost can't hurt anybody with androgel, and so like it
No,
it helped.
You can't help them much either.
Right, that's the thing, is like you can't really help them much. Mike Belkin, I just finished y'all's podcast yesterday, but he calls it andro jail because that they never get out of. So I thought that was pretty funny.
Right.
I'll credit him to that before just throwing it out like it's mine. But one of the things I want to kind of start with is whenever we start testosterone therapy, it is not uncommon for these guys to retain a little bit of fluid, and then they do get elevated blood pressure. So I kind of want to hit blood pressure first and kind of talk about this phenomenon. Have you seen that? And what is your typical approach in management with these guys whenever they're first starting?
Yeah, this does happen. And quite frankly, I mean, you can kind of predict who it's going to happen to. These are guys who tend to be obese, and they, specifically have higher levels of visceral body fat. Along with that, many of these guys have either diagnosed or undiagnosed sleep apnea. And quite frankly, most of them, if they're not already a bit hypertensive, they're pre-hypertensive. And basically, like, if you look at their labs, you're like, you either have metabolic syndrome or you're like you're on your way to metabolic syndrome. So with those guys, the first thing I try to do is prevent it. And so I don't blast these guys with high doses of testosterone, because it's just it's adverse side effect waiting to happen. So those are guys where I'll start at a much more conservative dose, like maybe even as low as 100 milligrams total per week. If we're talking about injectable, it just depends on how severe their other underlying problems are. And then, as they get healthier, as we address all of these other health-related issues, we can start titrating up that dose as needed. But, we've all seen it. The guy that comes in and he gets the 200 milligram shot at the local TRT clinic, and 3 weeks later, he's got huge cankles, and you're like, look, I need to put this guy on some Lasix, to get all this fluid off. That should never happen, right? I don't think, if you're an experienced provider, you can see the guys that are going to have problems. But like even the average guy sometimes can get a little bit of fluid retention, and this is almost always a transient phenomenon.
Yep.
It has to do with sensitivity to antidiuretic hormone, sensitivity to, or upregulation briefly of the renin-angiotensin system, which eventually the body compensates for, and then it tends to go away. So, I always warn patients about it. And so I don't get those complaints anymore at all.
Yeah.
Because I spot the guys who I think are going to have problems, and I'm not overly aggressive with them. And then the other guys, I when I do my initial informed consent, they know that this is a thing, and then it goes away. Now, if it doesn't go away and it's an ongoing thing and the pressures are elevated, well, first of all, you need a workup for that. Just make sure we're not missing, again, sleep apnea or some other underlying medical issue that's driving this. But let's just say it's, I'm pretty sure it's from the TRT. I mean, these are guys that respond very well, low doses of an ARB or an ACE. There are benefits to those drugs from a longevity standpoint that go beyond just reducing blood pressure. So I don't feel bad about starting people on those medicines. I mean, I don't have hypertension, but I take telmisartan, and I do that for a lot of reasons, including cardiovascular disease prevention. So there's benefits to those drugs regardless. But yeah, in general, a low dose ARB or ACE inhibitor oftentimes fixes the problem. What none of us like to see is them being put on, a milligram of an Anastrozole twice a week,
Yeah.
and then they end up staying on that for life because they're afraid that if they come off of it, or the provider is afraid that if they come off of it, the fluid's going to come back, and that's just not true.
It's crazy that I feel like I still see this every week, and I'm like, it is 2026 and we're still fighting this. I feel like it's been
I know.
something that should have kind of been crushed a while back. I mean, like, I read the Finkelstein study, not in 2013, but I think it was in 2013. But that's the one I reference a lot, to where it's like the estradiol is protective. There's the brain, the penis, everything is flooded with estrogen receptors, and so it's like I just can't believe it's a guy will come to me on it, or they'll reach out, crowdsource their information, and the forums and everything are still full of people. It's like, well, what's your testosterone to estradiol ratio? And it's like,
right.
Man, we don't need to worry about it, because then the biggest anxiety form is just the red H on the paper that's high on estradiol. So they go get it checked, and
of course,
now it's a uphill battle.
Oh, that shouldn't be there. That's dangerous.
Yeah.
No, we all have to have that. Like, I feel like I have that talk for patients just on like auto loop. I can just access it anytime, because you have to give it quite a bit. But I wouldn't say most, all of my guys now, they get it. They don't ask for it. I'm not opposed. Like, if they really want to know, okay, we'll get you serum estradiol, but just know in advance that we're not going to do anything about this. Nothing.
Yeah, and
it doesn't mean anything clinically to me.
Yeah, and sometimes it's just kind of fun for data. It's fun. I just checked my labs, and I should have thrown it on there just to see where I'm at for funsies. But I didn't think about it at the time. Because I'm kind of the same.
Mine because I take estradiol, so I do check mine. But
what is yours run
I take it
with the oral estradiol? Do you know what is your level run with it?
Oh, the last time I checked it before I had a dose increase, I'm actually due for a lab check, it's like 105, 108.
Yeah,
something like that. And
you're not ballooned out. You're still lean.
No, I'm a little weepy sometimes. But,
the Hallmark movies.
I feel amazing. I feel absolutely. In fact, I feel better on it than I did before. I don't know if it's placebo, but I feel better. So.
And since we're talking about, you take it for the cardiovascular protection.
Yeah. So I'll caveat this by saying, that this is what I do. I actually don't recommend this for patients, except in very specific situations, because the data on it in men is sparse, but the data in women is like overwhelmingly positive.
Right.
When it comes to estradiol and prevention of cardiovascular disease and slowing of atherosclerosis, et cetera. My specific issues, I have very high lipoprotein A, and I have confirmed calcified plaque in my right coronary. So I am addressing that from all possible angles, not just the lipid angle, not just the typical like blood pressure angle, nutrition, training, but also the hormonal angle. And so we do know that both testosterone and estradiol, mostly estradiol, can lower lipoprotein A, maybe 20 to 35, 40%, kind of depends on the study that you look at. Now, whether that's enough, I don't know, but I just had it checked yesterday, and I've had a sustained approximately 40% reduction in my LP little a since doing that.
Wow, that's
So,
wild.
you know, it's still above normal, you know, because I typically run 2.5 times the upper limit of normal, which is like well within the high risk zone. And so now it's just, you know, slightly above the reference range. So, but it's still high, but it's much better. So I do it for that reason. And I still take a statin. I still take ezetimibe. I take bempedoic acid. Like I crush my ApoB.
Yeah.
But that's only one piece of my strategy. So I don't have any guys taking oral estradiol, and you know, it's something. This is a personal decision for me. I don't. You know, I'm not opposed to putting a man on it, but we're going to have a very long conversation about that before we do it.
Yeah, for
Because
sure.
it is, you know, I'll be the first to say there's not great studies in men. Very limited data.
Yeah, and that's one of the things I've talked about in the past too. Like, and if there are studies, which I don't think anything has been done in like decades.
Yeah. Since the 90s, late 90s.
Yeah. Did they use like actual bioidentical estradiol as well, or
So this is the problem.
were
This
they
is the problem.
using conjugated equine estrogen or another synthetic estrogen?
Yeah.
You know, and
Every time I've heard a lipidologist or cardiologist talk about this, because it comes up sometimes in podcasts, is they all say, no, well, we tried that, and there was higher complication rates, higher death rates in, you know, the men that were receiving estrogen. And so what you do, you know, I'm like, okay, well, before I take this stuff, let me go actually pull the studies and actually look at this. And not surprisingly, just like with women, they're conflating oral bioidentical estradiol with synthetic estrogens like DES and ethinyl estradiol. And so it's technically correct. If you are on a synthetic, yeah, they did not benefit from that. So they had higher, you know, rates of DVT and stuff like that. The oral estradiol group, the problem with those studies, so first of all, they did not show increased complications, and they showed like modest improvements in lipids across all parameters, triglycerides, LDL, HDL. The problem is that they're small studies, and they went for only a very short period of time. Like some of them were just like 12 weeks, you know, so long enough to see the changes in the lipids, but not long enough to talk about events, not long, you know, outcomes, and, you know, potential long-term, you know, downsides to that. So yeah, maybe if they had gone 2 years, we would see, okay, there's actually a big difference here. So I'll be the first to say it's a bit uncharted, and I'm okay being my personal guinea pig with it. My labs, it's been going on like 2 years now, so my labs have always been good. So I'm going to get a CT angiogram here in the next month or two.
that's going to be my question. Have you had a baseline at all?
No, the only thing I've done is a coronary artery calcium scan.
Okay.
But I actually had a visit with a cardiologist here not that long ago. We're going to do a CT angiogram and just see what my anatomy looks like.
Yeah.
And then my plan actually is to do another. I'm going to stick on with what I'm doing, and then do another angiogram in like maybe 3 years, and then see. And you know, if there's no change from baseline, cool. I'm just going to keep doing what I'm doing. If I have disease progression, then I'll probably consider one of these new LP-A agents that's in the pipeline.
Yeah.
You know, because 3 years from now they'll be out. You know, I think they're in phase 3 trials right now. So that's kind of my plan.
Phase 3 trials for a while, and
they have, yeah.
But you know, you running your.
But I'm guessing within 3 years, like I think we'll probably have access to some. They'll probably be insanely expensive, but you know, that's how it goes.
Yeah.
So anyway, that's my approach for myself. Yeah, with estradiol is super important.
You have any idea if
why not leverage? I'm going to leverage it. I'm going to leverage everything I can.
Yeah.
You know, to not have heart disease.
Yeah, and you know, like you have even more of a sample size than me, but like I never saw a cycling woman have the cath lab activated for her. You know, it's always once they're in menopause, they lose that estradiol, and now they lose that protection. And now, and then they have studies where they do accelerate their plaque progression quite a bit once that estradiol is tanked.
They catch right up to men eventually. Yeah. And the ones that are prone to LP-A elevations, their LP little a is suppressed, obviously, when they're premenopausal because of the estradiol.
Yep.
And then their LP little a levels go up too.
Yep.
So,
Do you have any idea if the software for the CTAs there have the Clearly AI?
I don't think they do. I don't think Clearly has made it. Yeah.
Well, if you can
here.
get your disc, you can send it for Clearly analysis.
Oh yeah, you're
Yeah,
right.
so
Yeah,
I would probably do that.
Well, I'm coming back to the States for a vacation, so maybe I'll swing by.
Yeah.
Nice. Yeah.
Clearly.
Yeah. You can send it international mail and see if it makes it. But
kind of using you as a sample size, do you ever check any, or not a sample size, just a test subject? Do you do any non-lipid testing like homocysteine, CRP, any of those tests?
Yeah. I check my CRP. At this point, I just check it once a year. I've been checking my CRP for like 15 to 20 years. It feels like it's always less than 1. It's always, so it's sort of like, do I even really need to check this anymore? And I used to check my homocysteine as well on an annual basis. It's always been normal.
Okay.
So I kind of stopped checking it. Homocysteine, I do put it's in my initial panel when I see guys, but from everything I've learned about homocysteine, it's a marker of increased risk. Lowering it artificially with high doses of vitamins in the studies I've seen doesn't seem to change event rates. So we make the number look better. So the way that I address elevated homocysteine is with lifestyle interventions, mostly body composition changes. Obviously, make sure that all of their micronutrients are topped off.
Right.
But I don't mandate that they take mega doses of folate and B12 and other B vitamins. But I want those boxes checked for sure. And then it's just an indication that maybe I need to be a little bit more, even though, let's say, even maybe if their lipids are at goal, maybe I still need to be a little bit more aggressive because these people are at higher risk.
Do you know if the studies that you looked at for homocysteine, if they had used folic acid or folate?
So that's a great question. So they're old studies, so they probably use folic acid.
Yeah, and I can
but
understand.
I haven't pulled them up in a few years. So that might explain it, right?
Yep.
That could absolutely, yeah. If you're obviously, dealing with a
what is that significant?
THFR.
Just good.
So
Yeah.
like folic acid competitively binds the receptor and it'll outdo folate. So if you're continuing to eat your high fortified grain diet, like your folate that you're taking is probably not having the effect that you would like. And we already have an issue with folic acid metabolism. So like you're just building it up. You're not really doing anything with it. I could see how you didn't get a benefit there. Whereas you use folate, like that's the natural, real thing. And then we get good number reduction. So I think, I wonder if it's almost like the bioidentical estradiol versus estrogen kind of thing.
So it totally could be. And that, I'd love to see that study. Somebody needs to do that. Does it make a difference, right?
Yeah. And it's tough, like even for me, like I didn't even know that made a difference until Coulter came around, because I just would read them as synonymous, I just didn't know that made a difference. Truly.
I had to do a deep dive because I've got in THFR and my homocysteine when I first checked it was like 19 or like 22 or something. And I was like, ugh. And so started taking folate. Now it's like 9.
Yeah. So. Yeah, exactly. Yeah. It's kind of a no-brainer to me. Like you probably should be taking a little bit of folate regardless of what your homocysteine is.
Right.
It's definitely, they've done studies looking at DNA damage and DNA repair with folate supplementation. And it holds true even for folic acid, is that you get less errors in your DNA when you supplement. So up to 1 milligram per day. Beyond 1 milligram, there didn't seem to be a benefit. So, there's probably theoretically some anti-cancer benefits to that. Like it just seems like a no-brainer to me. It's dirt cheap.
Yeah, it's low barrier to entry. It's tolerated well.
Low barrier, right? So like regardless of what your homocysteine is, I probably sprinkle in a little folate. I mean, I take 1 milligram a day.
Yeah.
Well, I mean, if your methylation's not working right, it makes sense that all those things are going to show up.
Exactly.
So.
And I've never tested it, so I just take it.
Yeah. Well, and I think in the modern world we live in, our food isn't as nutritious as it was. So it's I think it's pretty much necessary to have a high quality multi to kind of address those nutritional deficiencies that are just going to be there.
Yep.
So.
One of the things that I was not on my radar at all until I did the podcast with Dr. Michael Twyman is colchicine. And he uses colchicine. And so I was kind of looking into it, like, when would I bring this in a guy? And, really it was a high-risk guy. Secondary prevention, it has a lot more. There's a Loco-Do 2 trial that kind of showed that it had some positive outcomes. And I was like, should I be doing this in primary prevention, meaning like a guy that hasn't had a cardiac event? And I wasn't really convinced, unless they have, like, for whatever reason, their CRP is 2+ every time I check it, and we don't know why. It may have some use there. But colchicine, is that on your radar? Have you been using that or looking into it at all for heart health?
I have not. I don't use it for primary prevention, although in my mind, I've got some scenarios where I might consider that. So yeah, it's always, so for secondary prevention, there seems to be a bit of a signal there. And it's exactly what you said. It's people who, have perhaps addressed their other cardiac risk factors, but they have, persistently elevated hsCRP or other inflammatory markers. And, it seemed to help a little bit with that. So yeah, I mean, you're not out in left field. I think if you want to try colchicine as a cardiologist or lipidologist for somebody who's already checked every other box. Now, for primary prevention, I don't know. We definitely need a lot more studies on that.
Yeah.
My general philosophy is, like, if you have an elevated hsCRP, the answer is not to smash it with pharmaceuticals. Like, why do you have a high hsCRP?
Yeah.
What are your nutritional deficiencies? Do you probably have excess visceral body fat? What else are you being exposed to in the environment? There's a reason you have a high hsCRP, and we need to do our best to figure it out. Now, let's say you've done you've just done everything you possibly can. The guy's 12% body fat, eats a very healthy diet, takes all the right supplements. He still has this persistently elevated hsCRP. I definitely believe in not. You don't treat numbers, right? You treat patients. So, then I would like some more data. Like, does this guy have silent atherosclerosis? If he's at risk, let's get him an angiogram and look. And if he has whistle clean arteries, you know what? I'm not going to put you on colchicine for the next 30 years, right? There's downsides to colchicine, but you know what? If you've got, like, a moderate amount of plaque burden, okay, maybe let's at least have that conversation. So the other thing related to CT angiography that I think might be, this is just my personal opinion, an indication for colchicine. Again, the guy that's done everything you want him to do, ApoB, everything, all the other risk factors are squared away, but you get one of these high res CTs like the Clearly scan, where they can actually quantify, like, not just the plaque, how much plaque you have, but how likely that plaque is to rupture. So if you have hot plaque, you have, very inflamed plaque, big necrotic course, very thin fibrous cap, they're getting better at identifying, like, that's only a 30% lesion there, but it looks nasty and it looks like it's about to pop. I don't know. Maybe I do want to add a pharmaceutical to try to cool that off and stabilize it, at least until my next angio. And if it's better, maybe then I can stop it. So I haven't run into that situation yet, but I've been thinking about, okay, well, what would prompt me to want to put somebody on colchicine? And that's something that came up in my mind. I don't think there's any studies on that, but it kind of logically makes sense.
Yeah, and the ER always having the bad things. Colchicine is one of those that if a kid takes it, it's like, it's horrendous.
Yeah.
I don't even, it's almost like a death sentence. I don't even remember the exact mechanism, but like.
Highly toxic. Yeah. Highly toxic.
I would if there's a young kid in the house, it would make me not really want to even consider it.
Be careful.
Yeah. Or at least just.
You don't want to
tell them about it, that it can be that bad, to make sure it's out of the way and they are very mindful of it.
No, this happened. You and I, we've seen this in the ER. Like, kids, they visit grandpa's house.
Yeah.
And then they get into dad or grandpa's verapamil, and that's one of those, like, one pill can kill.
Yep.
Things.
Calcium channel blockers are so scary. I mean, like, that's you just throw the kitchen sink at them, and they have to have so many lines. I don't even remember all of it, but I remember, like, is that the one with, like, lipid sink? and
all the way down. Yeah, you do have to do a lot of stuff.
insulin and all that stuff is
Yeah.
it's
It's nasty.
that's one of the
Yeah,
toughest
so
ones.
colchicine is a pretty toxic, like it's a pretty toxic drug, and even when I use it for gout, people don't like it. It gives them diarrhea and stomach upset and stuff. So
Yeah.
the low doses that they use for these studies probably don't have the GI effects.
I think it said
But yeah,
10% of people at that dose experience side effects. I don't know.
yeah,
Like on that same kind of doing everything. Why is your CRP high? Like kind of along the same lines. Twyman was doing a live on Instagram and he takes questions. And I said, well, if your fasting insulin's less than 5, do we need to even care what your, LDL is? And he got on there and it was a resounding, like, yes, that we need to continue to worry because, lipids or whatever, that's not the only reason that you can have a dysfunctional glycocalyx or endothelial dysfunction. Like he specifically listed, like maybe you have a heavy metal burden or whatever. So that's where functional medicine comes in. Like we can address that, So I think it was just kind of a good overall, like, what are we doing about your CRP and what is it? What's the cause?
Yeah, I kind of want to
treat patients, not numbers.
Yeah,
right?
exactly. I do want to just we've kind of danced around it, but as you're aware, in the ER, I didn't care about lipids at all and never needed to. And so I did not care much to learn about them until I got out and started this clinic. And then I was like, man, these guys' numbers are all over the place. Do I need to care? So I was like, all right, I'm going to do some research. And I wanted to be hip and not care. And so I read like the Great Cholesterol Myth and books kind of against it. And really, I was not convinced at all that you can 100% just dismiss cholesterol like social media claims to be. And so, there is more to it than just your cholesterol number, as we've already kind of said. But how are you viewing like cholesterol numbers? And we've kind of already been touching stuff, but what are you looking at with this cholesterol panel?
Yeah, so that you bring up a really good point. I'm just a knuckle dragging ER family practice doctor, so I try to make things very simple.
Yeah.
And I look at like 2 big boxes when it comes to atherosclerosis prevention. One is the lipids. And honestly, the lipids I think is the easiest one to address because we have great drugs, that can lower that. And then the other part of that is the vessel, the health of the vessel. And there's a lot that's where that's very, very complicated, right? The health of the endothelium, the health of the glycocalyx, systemic inflammation. Like, what are all the things that cause those ApoB particles when they enter the endothelial space to not leave, to become oxidized or become otherwise altered, and then be retained? That's where things actually get kind of interesting. So you have to address both of those. And the complaint in modern medicine, of course, is that we just focus almost exclusively on the lipids. And, we do that, quite frankly, because physicians don't get good training on the other stuff. We're okay at it, but, the nutritional stuff, the training, the lifestyle interventions are kind of pretty weak, right? If you go to the average physician's not going to be able to put you on a diet and exercise program. Like, they can't even put themselves on a diet and exercise program,
right,
let alone their patients. So, so that's where some of this other stuff will come in. But as far as you asked about lipids, so I try to go, what does the evidence show? At what LDL or what ApoB level do people have the lowest risk of events and the lowest risk of plaque progression from what we can do with the limited number of studies that have imaging? So with IVUS or even with CTA. And that number keeps getting lower, right? It keeps getting lower. So the current recommendations, at least for LDL, is 55 or less if you're at very high risk. So why did they pick that number? It's one, that's where the events were lowest. And then when they've gone in and done these imaging studies, that's where you seem to get the greatest number of people have plaque, at least plaque stability, if not a little bit of plaque regression. So for me, as an LP, I'll just use myself as an example, high LP little a, I'm automatically in a higher risk category. I've elected to keep my LDL well under 55. So it was 36 the last time I checked it.
That's impressive.
Yeah. Well, I think I need to do that, because I have to try to offset, there's not much I can do about the LP little a at this point other than what I've already discussed. So,
Yeah.
uh, so when a patient tries, asks me what should my LDL be or what should my ApoB be, first of all, I don't have a textbook answer for everybody. However, I feel like if you have plaque, you probably should be under 55 if you want to live to be 100 and not have a cardiovascular event. Now, does everybody need to be under 55? No, of course not. If you have an extraordinarily healthy other box, the endothelial, your metabolic, if you're really robustly healthy in that department, you're going to tolerate much higher levels of ApoB and LDL and not have the same amount of plaque progression. So maybe for, the metabolically super healthy guy, his ApoB can be 100 and his rate, he's not going to, put down plaque, or he'll put it down I think everybody puts down plaque, honestly,
Right.
but the rate is going to be clinically insignificant. So again, it's an individualized thing, but if you look at the studies, which of course took unhealthy Americans, they needed to get their LDLs very low and their ApoBs obviously as well very low in order to stop plaque progression. But if you do the other things and have a very healthy glycocalyx and very healthy endothelium, you can, I suspect, can likely have much higher levels of ApoB and not develop significant plaque. You still will develop some plaque. That's kind of a different talk, but I think the rates are going to be very, very low. So you need to do both. Like, it's sort of dumb. Like, why, I sort of feel like, why are we having this argument?
Yeah.
Like we need to address lipids, and we need to address, the health of your vessels.
I think that's where
And why would you just focus on one and not the other?
Yeah, I think that's where we see, like, your argument goes both ways. Like, you can crush someone's LDL and then, like, they still have
Yeah.
a heart attack in 2 years. I'm like, well, you did
Yeah.
nothing to address their metabolic health, their vascular health,
Yeah.
whatever. Do you mind me asking what your HDL and your ApoB were?
My HDL typically sits about 40.
Okay.
Yeah. I've never had an amazing HDL. Yeah. The highest it's ever been, I think, is 45, maybe 50.
Yeah.
Yeah. So,
Yeah. Did you check an ApoB on yourself?
yeah, my ApoB is typically between like 40 and 50.
That's awesome.
Nice. Yeah, I like ApoB so
Yeah.
much better because it's really looking at,
Oh, it
like,
is.
plaque,
Yeah.
like
It's the only one that I
LDL going to
really
make
care
plaque.
about.
Like, I care so
Yeah.
much more about ApoB.
Yeah. Yeah. But, as some background, like, just, my genetic baseline, my LDL all through, because I checked it in my 20s and in my 30s, was always 100 or less. I don't, like, by the standards of the day, my LDL was always amazing.
Mm.
And it's the LP little a that led to a positive coronary scan at 50. The same thing happened to my dad. My dad's LDL, was never above 120, but the dude ended up, before he passed away, like, more, I lost count of the stents. And they weren't just stents in his heart, they were stents in his carotid, there were stents in his renal arteries, stents in his iliacs. It's a total vasculopath. He never had an LDL over 130,
Yeah.
but his lipoprotein A was through the roof, just like mine.
Yeah.
So,
Coulter, can you describe what a LP little a is? We've said it 1,000 times, and I don't think I've actually even said what it is.
So it's like, I kind of layman describe it to my patients. I'm like, well, it's a little corkscrew shaped protein with, like, the ApoB molecule, that whole thing, and it's genetically, like, yours is shaped a little different. I take my explanation from Twyman, listening to him. He's like, well, it's got a little bit more of a corkscrew shape on it. It's a little bit different than what normal person. You've got more of it, and it allows itself to kind of embed itself in the intima easier than someone else. That's kind of the way I kind of touch it. Is that, like, perfectly textbook accurate? Probably not, but it gets the point across to the patient that they have something different about them.
Yeah, long story short, it makes your cholesterol more likely to be deposited and genetically, and we can't really change it. I mean, like, as you said, lowering it 40% with estradiol is basically one of the best case scenario, because PCSK9s can lower it a little bit, which is a really good drug class of medications, and they're clean. I hope they can be a much more affordable, accessible med option for most, because they do lower it a little bit and they do just crush ApoB, and they do it through a clean mechanism. You know, it's not,
Mhm.
people aren't scared of them like they are statins.
Yeah.
Right.
Like
And I'll kind of give,
like it'll bring your lipoprotein A down by like 26% or something. But you know, the
Yep.
cardiologist that I've worked with, who's like, that's great, and we'll take all the help we can get, but we need a 90% reduction to be significant. You
Right.
know, so like, you know,
Right.
you running your study of 1, like you have already
Right.
surpassed for Betha. You know, so
Well,
you're doing
exactly.
great.
Yeah, for a fraction of the
Yeah,
price,
and
right?
reducing the
yeah,
polyunsaturated
Yeah.
fatty acids in the diet will do it a
Yeah.
little bit. Niacin can do it a
Yeah.
little bit, depending on whether you want to
Yeah.
try that. You know, so
I was on niacin for almost a decade, before the niacin trials came out, and yeah, absolutely lowered my LP little a.
mhm.
But even despite being on niacin for a decade and having, like, again, better LP little a, pristine lipid panel, I went from a CAC score of 0 at age 40 to one of 16 at age 50,
Yeah,
and there was niacin in between there.
yeah.
So
Being a functional
yeah.
guy, it makes me wonder how much your circadian disruption and night shift contributed
Oh,
to,
huge. Oh,
you know,
yeah. Oh,
like your
trust me, I
stress.
thought
You
about
know,
this
I
a
think
lot.
like,
I guarantee,
yeah, I think that
yeah,
was probably
it
a
does.
huge player.
Yes, yeah. So
Y-
I'm looking forward to not having that in my life.
Yeah,
yeah.
Of course, now I have kids, so I have worse circadian disruption now with
yeah,
toddlers.
yeah, yeah.
Yeah, they're slowly killing me.
You know, it's funny. That's one of there was a study, and I think it was that night shift was close to about smoking 2 packs of cigarettes a
Yeah.
day.
It was in nurses. It was a 5-year study in nurses. Yeah, that did 12-hour night shifts.
Yep, and that
Yeah.
was the decision for me to leave the ER. Truth, like,
Yep.
I mean, I was already kind of on my way out. I had thoughts of doing this clinic today, and I knew I couldn't do it alternating day and night shift like I was.
You
And then
can't.
I
You
was
can't.
listening to an MRAP, and they were talking about that study, and I
Yeah.
was like, you know what? I applied to urgent care like that week, and but that was
Yeah.
the nail in the coffin to
Yeah.
get me to do it.
Yeah, I can look at.
Sleep is like foundational, man. It is. Yeah, I didn't learn anything about sleep in medical school or residency, even though we probably should have. But and everything that I've learned since then, it's if your sleep is not right, like, ain't nothing right.
Yep, I
If your
tell
sleep,
my patients
No,
it's
is
the
not right.
bottom of the
foundation.
pyramid in terms of health and
Yeah, yeah,
foundation.
Yep.
yeah,
Yep. Regulated circadian rhythm and good sleep hygiene is the foundation of all health. That's what I tell every single one of them.
yeah,
And they look at me kind of funny.
yeah. That's a great way of putting it. It is a foundation. It's like it's the
Yep.
bedrock.
You can't out
So
exercise bad sleep. You can't. I mean, you're not going to
yeah,
overcome it. So
nope. No, and that's the one thing, like, in my my entire career, like, that's the one thing, like, it's been outside of my control, and
Yeah,
haven't been able to get a handle
military.
on that
yeah,
Yeah,
until now. Yeah, military was obviously terrible. When you're deployed, you're up all the time, and
yeah,
it's just part of the job.
yeah.
yeah.
I
So
looked
one
at
of the
pictures.
things
Sorry.
you can go ahead, Coulter.
I was just saying, I looked at pictures of myself. Like I didn't know about that study with the nurses, but look at pictures of myself, before starting night shift in the
Uh,
ICU and then flight nursing, and then look after it. I'm like, my goodness, I aged so
what the
significantly. Yeah,
hell? Yeah, I hear that.
So that's what I was going to transition to, why sleep apnea is such a profound negative to heart health. Like, that's one of the things that if a guy is running high, I'm putting him on meds. He's got excessive erythrocytosis. I put him on testosterone.
Mhm.
I can almost guarantee he's got sleep apnea. And so I have a super low threshold to getting a sleep study on a guy just to make sure that's not contributing. Because I've got them, if I can get them compliant with the CPAP and stuff, I've been able to withdraw their blood pressure meds. And,
Oh yeah.
like,
Oh yeah.
they
Yeah,
just,
absolutely.
whenever you're not suffocating a third of your life, it's just positive. And I can somewhat sell it like, look, this is probably going to have just as much of an impact on your energy, your brain fog, as testosterone will. It's going to, just because it's, again, you won't be suffocating a third of your life. And so let's try and get you
Yep.
compliant with this
yeah,
CPAP.
yep. I have so many people that they're just so hesitant, and I tell them, like, suffer for 2 weeks and like try to power through and wear it
Let's figure it
and
out.
figure it out. And while we're at it, let's have body
Yeah.
recomposition and reduce your neck
Yep.
circumference. And it literally makes everything better. If I had somebody with high blood
Yeah.
pressure or dysrhythmias
Yeah.
or, whatever it is now, secondary erythrocytosis, anything. They're like, most people probably think I'm pretty laid back. And then I start talking about sleep apnea and they're like, what happened to the guy that was really calm and positive in this appointment? Why is he so hard about this? But it's such a huge impact.
And so that's another good.
Well, patients they don't appreciate just how bad sleep apnea is for you. Just bad for your physiology over time. And, I get to see the end stage of that in the ER. I've seen multiple guys come in that have had untreated or undiagnosed sleep apnea, or they've just like chosen to be non-compliant with it. They're just like, screw it, I'm not doing it. And eventually those guys, they develop severe right-sided heart failure.
Yep.
Their pulmonary artery pressures are always high.
Yep.
Their right ventricle eventually gives out and they come in fluid overloaded and drowning. And, honestly, like probably that could have been prevented. It's just, this is 30 years of untreated severe sleep apnea. This is what it does to your heart. It destroys your heart, destroys your blood vessels. It's pro-inflammatory. And it's a major, major thing. So it's not, I know it's an inconvenience, right, to have a CPAP. I hate my CPAP.
Yeah.
I hate it. Even now I still hate it, but you got to be compliant with it.
Nobody wants to sound like Darth Vader, but it's totally worth it.
Yeah.
And
it's totally worth it.
I feel like one of the main things too is like the vast majority of people that have, I say, hey, have you had sleep study? They're like, yeah, my primary did have a long back. They told me I needed to wear this thing. I mean, they didn't go into the fact that it increases mortality and morbidity across basically all diseases. They didn't give them the fear factor that they needed for that. Whereas like, the teaching from us in cardiology, like about whatever is a lot more, this is serious. We need to like really get after this. And I wish that carried over to sleep apnea across the specialties.
Yeah. Sometimes the reason patients are non-compliant is that the doctor just didn't take the time to like explain like why do I care about this? Why is this a big deal? And if I get it, you got a 20-minute appointment in your office, you can't hit everything, but the sleep apnea is one that you have to be like, no, like this one's important. You need to listen up.
Yeah, and so this is a good transition to elevated hematocrits on testosterone and how much of an impact this is. And so, do you have a number or anything? The guidelines recommend hematocrit of 54 to do phlebotomy. And I just kind of, I kind of know your thoughts, but I just want to hear just kind of your thoughts on phlebotomy and hematocrit control for, testosterone patients and heart health.
I don't have as big a problem with it, but it does, obviously happens a lot. If you prescribe testosterone, you're going to see some high hematocrits. So my kind of stock policy with blood donation is, if for whatever reason your hematocrit gets up to the point where you feel like you're symptomatic from it, by all means, like go donate some blood. God knows we use enough of it at the hospital. We could use some more.
Yep, exactly.
So, go donate some blood, and if it helps, hopefully it'll help you feel better. But then we need to do something. Then we need to find out what's the root cause of this. Is it just the testosterone? Or like Coulter was saying, like, is this sleep apnea? Probably both. And then we need to adjust your protocol. We need to do something so that we don't have to revisit this again. And so that when you donate blood, it's for altruistic reasons only, and not for medical reasons or for symptom resolution. So obviously the guidelines talk about 54%. It's an unfortunate number. It's really not based on great evidence at all. It's mostly expert opinion, but unfortunately, that's probably the legal standard that we would be held to if there was ever an adverse outcome. So I kind of don't like to see numbers above that, but it's not because I'm worried that my patient's going to stroke or have a DVT or PE the next day. It's mainly for medical legal reasons. My hematocrit routinely runs above 54%, and I don't care. I'm not worried about it, and I'm asymptomatic. So it's the actual evidence showing that secondary erythrocytosis from testosterone in an otherwise healthy man is puts you at inordinate risk of thrombosis is actually really spotty, if not non-existent. You can make a mechanistic case for it, but when you look out into the wild, and I don't know, you just don't it's very actually tough to prove scientifically that it's an issue. Now, if it's for other reasons, obviously you have polycythemia vera or whatever,
Right.
that's a problem, right? Those people do need to donate blood, but that's not the same condition. The
No.
doctors they see high hematocrit and we're trained to think malignancy. We're trained to think something bad is going on.
Yeah, and that's what, in polycythemia vera, there's a platelet dysfunction, which is going
Exactly.
to increase chance of clots. Whereas
Yeah.
in secondary erythrocytosis from testosterone, there's no platelet dysfunction. So the red blood cells aren't getting stuck. They can still pass freely and everything. But, we're in the same boat. If it's high, it does trigger something. Something's got to be done. Do we get a sleep study? Does the patient need to start low intensity, steady state cardio or some sort of get any cardio? Are they hydrated?
Well, the answer to that's yes, always yes.
Yeah, I know. So it's like some of these guys are still cardio resistant, and it's like, come on, bro. I mean, walk on an incline, do the stair mill, ride a bike, walk with your kids, find something to get a little sweaty, a little out of breath most days. It's just, it's what we need to do. Hydration. Some guys do just seem to really crank up their numbers on injections. And so we do switch them to cream. And I think that has a good use. And it seems to have less of an impact. Or just continue to decrease dose or more frequent injections. A lot of times that'll kind of normalize it a little bit. Maybe sub-Q over IM. I know that's somewhat of a big debate as well, but I feel like maybe the less peak on sub-Q, especially if you're doing daily or every other day, so it's not you're not getting a lot. That's kind of how
it's worth a try.
Yeah, that's kind of how we approach on managing it, just to see if we can get them, just closer, and if not under the number. So again, we're not having to say, oh, go donate every time. Because on the flip side, what I've seen, again, from a cookie cutter clinic or a PCP or somebody who they're just like, hey, you're on testosterone, you have to go donate blood every 8 to 12 weeks. They'll come in with like single digit ferritins and they can't function. Now they're back to poor exercise capacity. They're weak, they're restless leg at night, dizzy upon standing. And it's like, well, why are you still
happens all the time?
Yeah, why are you still donating? And they're like, oh, they told me if I want to stay on testosterone, I have to. And it's like, oh man. And it takes forever to get the ferritin up. I mean, that's not just like, here, take this ferritin pill. It's either get infusions or 6 to 12 months of consistency with it.
Yep. And it drives further erythrocytosis, right? Because of hepcidin. So most of the iron that you take it doesn't go into your ferritin stores. It gets shuttled to make even more red blood cells. And so that it becomes this vicious circle.
Yeah. I also see like the
so
thyroid.
best not to get in that trap.
Yeah. Sorry, I didn't mean to cut you off. I was just saying, I feel like you can see the thyroid take a hit too a lot of times on their blood work. Like the free T3 starts to suffer. So generally they just start to feel really cruddy.
Yep.
Yeah, and then then
I've had a number of guys come to me with that specific issue.
Yeah, and then thyroid is hard to manage.
It should never happen.
Yeah, it shouldn't be. Again, in 2026, I feel like we should be past this and like, hey, let's just manage testosterone appropriately. Stop doing your 200. It's fun. So your 200 every 2-week injections. But why that's still there? Because we just looked this up the other day. On my like Medscape app, or if you go to Up to Date, it says 100 to 400 milligrams Q like 1 to 4 weeks. And it's like,
exactly.
What kind of where is this even coming from? It's like, and this is so, and if that's. So if I'm, looking at from a PCP who is like, man, everybody's talking about testosterone, I'm just going to give it a go. They didn't get any training. They look up on Up to Date and they're like, okay, well, 100 every 4 weeks seems pretty conservative. I'll just kind of help top this guy off. And little do they know, they're chemically castrating the dude. And, and then he feels worse. And they kind of show up to us at that point anyways. But, that's kind of where I think it happens at some. They have good intentions to try and help, but that's what the guidelines show.
Well, just to go along with that, years ago, my father got on testosterone in his 70s, and one of his physicians, who was well-meaning, very good internal medicine doc, but just outside of her depth with testosterone, had him on 50 milligrams every 4 weeks injection.
Yeah.
Yeah.
I had that.
So we
I had that
fixed
2
that
months
pretty
ago,
quick.
like
Yeah.
that exact protocol, because he's an older guy.
Wow.
And
Yeah.
I just was like, oh my
Every
gosh.
4 weeks.
Yeah.
Man.
And they made him come
on that
in.
roller coaster.
Yeah, they made him come in for an injection every time, and was like, oh man, I wish I would have known this is what was happening.
Well, this is why we're in business.
Yeah, exactly.
I mean,
It's why I have an entire business, truthfully.
exactly, because the bar has been set so low in the rest of the mainstream medical world.
Yeah.
So
yeah, and so I think that's kind of the biggest. I think the erythrocytosis is kind of the biggest one. Going back to kind of blood pressure. One thing we didn't talk about is nitric oxide. I kind of like you can't really measure that, so it's hard to really talk about it with patients. But that's one of the biggest things that comes up. It comes up more with me because we also have like an erectile dysfunction portion of talking about testosterone, and erectile dysfunction. I consider the canary in the coal mine for cardiac disease because it's going to precede coronary vascular disease. The penile arteries are 1 to 2 millimeters. Coronary arteries are 3 to 4, so they're smaller. They're going to it's going to precede it. And some of these guys just have poor nitric oxide levels, and we just can't check it. But those are the guys where like Cialis, tadalafil doesn't work, and even Coulter, from a functional aspect, has helped us, somewhat help improve nitric oxide levels, and
you actually can check it. So this is just a super easy way. So they make the little test strips, and you want to do it when you haven't eaten. I think within like 60 minutes or something like that, and it's just the saliva. It's like maybe it's not perfect, but it's something to show like, hey, yeah, you have low nitric oxide. You have you don't have a lot of diet to support the manufacturing of the nitric oxide. So here's a few things we can try. Here's a bottle of nitric flow. Like, let's see if we can get that up. And lo and behold, the tadalafil starts working. So we didn't have to go up on the dose. So
there's also a commercial device which is pretty cool. You can measure flow mediated dilation.
Cool.
Forgetting the name of the commercial product, but basically, you pump up a tourniquet, you keep it on there for like 5 minutes, you make the limb ischemic, and then you release it, and then when it reperfuses, if you've got nice healthy nitric oxide levels, you see the artery just balloon on ultrasound, and usually it like more than doubles in diameter sometimes, and that's a sign of good healthy endothelium, good healthy nitric oxide production. But if it doesn't, if you've got poor flow mediated dilatation, that's a big red flag. So that's another, like, that's an indirect way of checking it.
Is that an IMPAT?
And so that could be
what that's
useful
called?
for screening.
IMPAT? I can't. IMPAT device. I can't remember what that's called.
The company is like, it's on the tip of my tongue, but I can't remember what
I forgot about
but that. You could, that would be pretty useful, especially like in your young guys. You get guys in your 20s and early 30s, and they're starting to get a little bit of ED, but that can be something that they can say. You can say, listen, man, you need to fix this now, because this is a harbinger of things to come for you in terms of vascular disease. You have endothelial dysfunction, which is the first step in atherosclerosis. So let's get aggressive on this. Let's fix it.
Yeah.
It's called an endopat, and Dr. Twyman.
Endopat.
Oh, that's it. That's it.
He's got it
at his
clinic in St. Louis, or wherever he's from. Yeah.
If I have a brick and mortar clinic, I would get one of those for sure.
Yeah, it's pretty cool. I think he was doing it at Silverback last year. I should have had him do it on myself.
Oh, really?
Yeah, I should have had him do it on myself. I just didn't go over there and get it done.
I would totally wait.
Well, one of my favorite studies with that device and that technique, one of my favorite studies is where they gave men an Anastrozole and checked it.
Oh, no way! There's a full.
You can probably guess what happened, right?
Yeah.
Yeah, their flow mediated dilatation tanked, and it stayed tanked for many days after just a single 1 milligram dose.
Yeah.
So
And
Yeah,
that's
let
one of
me
the,
show you what endothelial dysfunction looks like. Here, take
yeah.
yeah, exactly. So you're literally, inducing, and the interesting thing about it is their serum levels didn't change a lot. I mean, they went down, but like they didn't crush their serum levels, but they crushed their ability to produce nitric oxide.
Yeah, exactly.
And it's just that's another data point that shows
Yep.
like the serum levels don't reflect what's going on in the tissues.
Yeah.
So
Yeah.
Yep.
I looked it up, and it says that like favorable normal endothelial function, you'd see generally greater than 7%. I assume that's talking about flow mediated
yep,
dilatation, and
yeah,
in young
sounds
people, 8 to 10, greater than 8 to 10% is common in young people, so, or healthy individuals. So
perfect.
another one I'd like to see would be or have a place that I could send somebody is the carotid intima medial thickness. I think that would be cool
Yeah,
to have a little
that's
bit
easy to
more
get. Yeah, yep,
people and
Yeah.
use it more
So
routinely. I mean, it's like having
that's
steps
a routine
before
test.
I have
Yeah,
to throw it into, getting a coronary CTA. Not that I'm opposed. I'm like
yeah.
gung ho about that for most people that need it. But
yeah, one of the things I want to,
Well,
oh, go ahead.
go ahead.
Hit your
Oh, I
topic
was just going to
first.
say that the ultrasound is nice because you could literally like you could do that annually. I'm
Yeah.
not going to radiate someone annually
right.
with a CT, but obviously an ultrasound's harmless. So
Yeah,
Yeah.
and you
why not
can,
do it?
the thickness you can correlate, you can see your treatment,
Mhm.
probably a little quicker on that,
Yeah, potentially. Yeah. Hmm.
and see what's going on with
Yeah.
there.
And you can, if you've got bad carotid disease, you can assume you have bad coronary disease and disease everywhere else too. So
Yeah.
you could even just use that.
One of the things I want
One
to
big
touch,
highway.
just because it's a hot topic, is Coulter's threshold for statins is way higher than mine, and so one, I just
Mhm.
kind of want to hear your reason for not using them as readily available, and then I kind of will say why I or when I use them and that kind of stuff. But I do want to hear Coulter's side of just like almost never, but I'd never say never in medicine
Yeah.
or anything.
Yeah. I
But
don't use absolutes, but I don't like the general kind of practice of, oh, your LDL is 130, you need to go on a statin, and like that's the end of the conversation. I don't agree with that. I think there's just so many other things that matter so much more in improving your vascular health, and then like even in like mitigating elevated lipids. But obviously, like if we are if we got somebody that's already got a significant plaque in their right coronary artery or whatever, like you have yourself and your family to think about. And like I would never, look down on somebody for going ahead and doing that. I'm just the whole idea of just throwing statins on, I'm not okay with. And I think that anytime you want to talk about it or bring it up, and they kind of look at you funny when you're like, well, we can cause mitochondrial dysfunction. Maybe that can be medicated by CoQ10 supplementation. I don't know what the extent could be, but there's that. We can have some gut dysfunction. I mean, mitochondrial health is a huge thing in regards to cardiovascular health and just longevity in general, lifespan. That I think using them kind of just as freely as people do, I can't get on board with that.
yeah, and I especially in secondary prevention, I think they really need
Yeah.
to be used just to stabilize those plaques and stuff.
Right.
Primary prevention is still a tough one, and like I will probably reach for them again at lower threshold of Coulter and like these lean mass hyper responder guys that are just cruising with their ApoBs close to 200, just because I don't know really what else to do, and it's like, okay, now I have let's say a 50-year-old guy with a coronary CT of, well, let's say a calcium, not a coronary CTA, a calcium scan of 0, his LDL is 200, like, what do I do with this guy? Those are the tough ones. Do I just keep checking it every 3 to 5 years? Do I get a CTA? How do you look at those guys, Coulter?
I think that is telling me maybe I've got a little bit of time to do some other background work before we have to commit. And obviously, if the patient's like, no, I want to do it, like, let's do it, then okay, sure. But I don't want the patient to feel like forced, like I'm like, you will take this statin now, or you're not my patient anymore, you know? So, but, you know, we could try some berberine and citrus bergamot and aggressive body recomposition. And, you know, are we getting adequate sleep? Are we addressing the foundation, regulated circadian rhythm, diet, you know, exercise? Have we done all the things? I would like to try all those first. And then, you know, have we thrown ezetimibe on? And I know that's not the progression, you know, as far as like what a guideline would say, but I don't know. I'm the black sheep of cardiology. So, you know, I kind of, is it warranted yet? You know, I had plenty of people where we're on stent number 3 or heart attack number 2 or whatever, and like I have no reservations. But if I have a patient that is completely willing to have radical change in their life, like I want to let them do that.
Yeah. You know, and if the PCSK9 inhibitors were more available, I mean, they're just a cleaner mechanism, you know, and like, so
super
those are
very specific in their action.
Mm-hmm.
There's no,
I think in 5 to 10 years, you know, we're not going to be prescribing statins.
Yeah, something, the AI will help figure something out to just get a better, you know, again, just cleaner. I mean, bempedoic acid's cleaner, ezetimibe's cleaner. Ezetimibe's just kind of weak alone. You know, like that guy with the LDL of 200, he's just not going to get to LDL of 55 on ezetimibe, you know.
Right. Obviously, if we need to get him to 55, that's a different conversation. But like, I'm not in cardiology now. So like, I'm not seeing, you know, 10 out of my 30 people needing that aggressive lipid lowering, you know. I'm just, I mean, and I didn't even touch on like the whole metabolic dysfunction and meta-analysis that are showing an increased risk of type 2 diabetes. I mean, it just makes me wonder, you know, my dad, my whole life was fine. And then at about the 10-year mark on a statin, we've got diabetes. Like, I don't know, maybe it's all his diet. I don't know, but it does make me wonder, you know, how significant is it? You know, is it correctly or truly portrayed in the studies, like the risk for that? And so if I'm trying to improve metabolic health and then I'm giving you something that maybe is taken away from that, that seems kind of counterintuitive to me.
Yeah. I just look at it as a simple, you know, risk benefit, you know, equation essentially. And what all the statin studies show is that the higher your risk, the more you stand to benefit from statin therapy. So, you know, the fresh 3-vessel cabbage who's already been stented twice and had 2 events, that's kind of an easy one.
Yeah,
all right. The 25-year-old with an LDL of 160 and no other risk factors. Yeah, I mean,
that's kind of where I'm coming
probably
from.
not.
Yeah.
This is where I like imaging. You know, I get accused of overusing imaging in the ER all the time, but I find it useful. You know, if you're a 45-year-old guy and you get an angio, you're asymptomatic and you've got, you know, like a couple 30% lesions and maybe a 40% somewhere. You know, are we really in the realm of primary prevention anymore? Like you have the disease.
Yeah.
Yep.
So whatever you have been doing up to that point is not adequate.
Right.
Yep.
So yeah, and I agree 100%.
We need to come up with a plan, right? And so it doesn't have to include a statin. Like that's so nice. We got other options right now. If your LDL is 250 and it's for genetic reasons, like you probably are going to need a statin until we come out with something better.
Just get you on Repatha right away.
Get you on we should, right?
Yeah.
If your
insurance I'm a lot more
will
okay
pay
with.
for it. Yeah. Well, the VA, I went to try to get on Repatha a number of years ago, and they knew I had plaque and everything. They said, "I'm sorry, you're going to have a heart attack first."
I know that's just after the event. They'll
like literally to my face, physician to physician. That's what they said.
Wow.
So not everybody can get Repatha. Eventually, you know, market forces, et cetera, it'll become more available. But yeah, so for now, I'm on rosuvastatin, and I take ezetimibe.
Yeah, which I mean, rosuvastatin is typically what I use. It's hydrophilic, so you just don't get as much of the side effects like people are so scared of. And so I think the side effects are overblown. And Coulter's even disagreed with me at times because he saw it in a cardiology clinic But it's like you can do low dose, and rosuvastatin's so good you can do a low dose of it. Every other day. And you'll have meaningful reduction. And so again, it's not I'm putting everybody on it, but if there's a guy that I'm deeming high risk, but then you're right too. Like, let's just get some sort of imaging. And again, if you have even calcified plaque of 100, not even a CTA, then we're in different territory here. Now we're in damage control.
And I would agree, because it doesn't take a cath to move us into secondary prevention.
Right.
I think we see it. Right. It's there. It's already happening. Like, okay, the game has changed, but that's.
One of the things I think the general public doesn't know, and honestly, I wasn't really even aware of this until not that long ago, but atherosclerosis begins in childhood.
It's crazy.
So this is like part of being a human being. Every mummy they've ever dug up from 5,000 years ago, literally, that has soft tissues preserved, they all had atherosclerosis. It's part of being a human. If you live long enough, unless you're maybe one of these PCSK9 mutant people, but you're going to have some atherosclerosis, right? So there's nothing wrong with coming up with a sort of a lifelong game plan of like, how do I manage this? And of course, it doesn't have to involve drugs, but at some point it probably will.
Right.
And your individual threshold for starting drugs is your individual threshold. Like my boys they've got a 50% chance of inheriting my Lp(a).
Yeah. So
I think you can. I forget the age. I think you reach adult levels by like age 5 or something like that. Yeah. So, at some point, like after that, I'll get it. I'm going to have them check for that. And when we're going to obviously try to be as healthy as we can with them as they get older. But at some point, I'm going to have that conversation with them. I'm sure there'll be a lot of other options at that point.
Yeah. Hopefully.
Yeah. Like my dad didn't find out about it until the horse had left the barn. I found out about it in my mid 30s before, serious damage has been done. And so if my boys have it, I want them to know from as early as possible as well, and come up with a plan. People need to think. Everybody is short-sighted, in terms of its natural human nature. But I really think you should have a 50-year game plan for your health. If you're in your 30s, like, you really need to think about what life is going to be like in your 80s, and start making changes now.
I mean, it's kind of like
it totally matters. It really makes a big difference.
Yeah, that's what influenced my decision to, go on testosterone in the first place. I was like, do I want to be like more muscle? Well, but that didn't play into the decision. I wanted cognitive benefits, and I wanted, what I believe to be cardiovascular like risk reduction. I'm going to be able to live a healthier lifestyle. I'm going to get some endothelial function benefits. Like, I don't want to be in the same boat that my dad was, where he had his first heart attack at 48, and he had multiple stents and finally got a single bypass. And, thank God he's doing well now, but I'd like to avoid all that. And I'd rather take a statin than go through all that and then possibly risk getting heart failure, because that's even worse than existent.
Absolutely,
and so, where I get kind of, like I said, if it wasn't clear already, like, I'm more of the, we just don't know yet. What's this person's risk? I want to figure that out before they're thrown on. But after we know, all right, did the game change or not? Like,
exactly. Yeah. It's amazing to me how many of our medical colleagues who I know, they see the same stuff that, we did. You worked in cardiology, Coulter, and, Mason and I were in the emergency department. You see the end stages of this stuff. Like, and so many of them, I don't know that it ever dawns on them that, like, no, this is going to be you.
Yeah.
Unless you fix this. I noted when I was a medical student, that's when it, like, the light bulb went off for me. I was like, shit, I don't want to end up like this. But, like, I've had, this is not a joke, in the last 2 years, 3 of my physician colleagues have had MIs.
Wow.
Yeah.
That's wild.
Yeah.
3.
I think the ER.
Two of them were younger than me.
Wow.
Oh, man.
Were they ER physicians working night shift and stuff too?
We had ER, anesthesia, and cardiology.
So all people that get woken up in the middle of the night.
Exactly.
Yeah. I'm that annoying, like, always preaching.
There might be something to that.
The ER is, it's funny, like, I feel like there's that stereotype of the ER with the Dr. Glockenflecken. He has the bicycle helmet, but it's like, I feel like the ER doctors and staff as a whole are the ones that are, like, doing all this exercise stuff, whether it's jujitsu, biking, long running, they all seem to have a physical aspect because they're like, we see the end stage of it all the time. We just don't want to get to that. So I feel like they're the ones that are a lot more into these, physical sports to try and do that. Plus, probably the adrenaline
I'd be
aspect.
curious to see like if they sampled like what specialty is the most physically fit.
Probably ortho
I don't
bros,
know.
man.
I see a lot of guys in the ER, a lot of physicians that are just like a wad of cookie dough. So
Yeah.
as well. So,
Yeah, my cardiologist I worked with, his wife got onto him and goes, "Nobody's going to listen to a fat cardiologist. You need to lose weight." And,
right.
he lost
Right,
like
exactly.
80 pounds or something. Like, he's done
Good
great,
for him.
but it was
Yeah.
hilarious. Kind
of on that point, something that doesn't get talked about a lot with the lipids and stuff, but I think makes a big difference are the GLP-1s, in terms of heart health. They're not really in the conversation of like lipid lowering and stuff, but man, we use them a lot. And the amount of, the lipids that drop, the HSCRP that drops, the weight that drops that helps sleep apnea, I think they're very much heart promoting. And sometimes on social media, they get a real bad fear mongering as well. But, it's like, use them responsibly. Don't crush your diet to nothing. Use them as a little tool. Because it seems like the anti-inflammatory benefits are even independent of the weight loss. And so, of course, weight loss is great, especially if you need to drop 50, 60 pounds. That's full force ahead anyways. But I've seen a lot of good results with them because a lot of our patients are kind of on both as they go and just really can see improvements. One, in terms of body composition. Testosterone helps maintain the lean mass. We're encouraging, high protein on it, resistance training. So you have to use them responsibly, just like any other medication. And they can be overused and really even abused if it's an old lady crushing her appetite, not getting protein, not moving, not doing resistance training. She is prone to getting osteoporosis, sarcopenia. And that's the last thing I want to do to anybody over 60 is sacrifice any muscle, But long story short, I think they can be used responsibly and are very much cardioprotective at the same time with all of this.
I agree.
Yeah.
I think anybody, regardless of if you're in a medical specialty that treats cardiovascular disease, I think by default, you need to be an expert in obesity. Because like you want to talk about root causes, like obesity, excess visceral body fat is like, it's right up at the top of that branching chain. If you fix that, like all of these downstream issues, lo and behold, they all get better.
Yep.
Right. So you fix their hypertension, all of a sudden their lipids are in line. All of a sudden their CRP is better. Maybe even their homocysteine, who knows? All of these things that we're addressing them like down at the bottom with drugs and even and lifestyle things and supplements. But if we just focus at the very top of that flow chart and get the body fat under control, I always say like there are very few medical problems that get worse at 15% body fat.
Yep. Fair point.
Almost everything gets better, from your mental health to your erectile function to your metabolic health. Everything gets better at 15% if you can get there.
I've been stealing that for all my visits lately. I heard you say it the other day and I was like, yep, that's good. That's stolen. I'm using it. And no, I mean, from cardiology perspective, I had so many patients that were like, man, I don't want to be on all these drugs for the rest of my life, because a lot of these people are coming in crazy high and I'm starting 2 at once and they're really discouraged. I'm like, this doesn't have to be your life. Go lose 20 pounds, walk for 60 minutes every night, lift twice a week, meet your protein goals, body recomposition. And then lo and behold, they lose 20 pounds and they can come off one or both. And so
it just, unfortunately, there's so many that just like even that's just too big of an ask, for them. And so those are the ones that end up on 15 different drugs, because that's the only, if you're not going to do the lifestyle part of things, then the only other stuff I have in my toolbox is going to be medications. So,
and then that way you can get your big pharma check with it too.
Yes, God, I know. Thank God for that.
Mine must have got lost in the mail.
Yeah, me too. I'm gonna file a complaint.
Yeah. One last thing, I mean, we did an entire podcast over the ancillaries and everything. So if people want to watch that we go much more in depth. But I was just going to kind of say, like testosterone seems to be cardioprotective until it's not. And really I don't really know where that threshold is. I don't think we'll ever know. But, and then if you start throwing other anabolics, even now you throw in tren, you're now in the negative cardiovascular aspect. But do you have any idea where you think that threshold is in terms of testosterone's cardioprotective until it's not?
I don't know. I don't know what that number is.
I don't think we'll ever know.
There's never going to be a study on it. We do know from, the short term, like the Bayesian studies, that people tolerated surprisingly well, like 600 milligrams of testosterone a week, and they didn't skew their lipids, and they didn't really skew their blood pressure. There were slightly more adverse events, obviously, at the 600 milligram dose, but people did surprisingly well on that. Now that does by no means indicates that that's a safe
do not
thing
take
to
that
do
as
smart.
Yeah.
Please, don't say, Dr. Andrews said I could take 600. No, I didn't say that. So I don't know what that cutoff is. What I do know is that, as I said at the very beginning, testosterone is a naturally occurring, it's a bioidentical hormone. Your body knows what to do with it. It knows how to make the metabolites. It knows how to process it. It knows how to eliminate it. This is something that it's been designed to do. The issues with the synthetics are often that this is an unnatural hormone. It may be just one methyl group off, but it's not naturally occurring. And therefore, all of its downstream metabolites are also not naturally occurring. Your body is not used to seeing those. And so it shouldn't be a big surprise that there's going to be more adverse effects with that. So my gut feeling is that safe threshold for testosterone is actually quite a bit higher than certainly mainstream medicine thinks it is, but I don't know what the number is.
But I think that
I definitely know that 200 milligrams of testosterone is way safer than 200 milligrams of nandrolone.
But I think the anabolics are where testosterone got its bad rap for worse cardiovascular health, because at the time people weren't looking at like TRT. They look at testosterone as bodybuilder, abuse, and multiple other compounds at the same time. And so. We did an hour and a half of that of an entire podcast, so we don't need to dive much further into that. But we're already almost about an hour and a half into this one. Any other topics that y'all want to touch on heart health and testosterone that we didn't? I mean, I think we kind of covered.
I don't know. I would just encourage guys, like I said, this disease starts very young, so. I know it's a lot to ask a 20-year-old to start thinking about their heart health, but I think they should. I wish I had started thinking about it even earlier than I did. So, you got to, whatever your plan is, if you're one of these people that are like statins are poison and, screw big pharma, like I'll never take a medicine. Okay, cool. But like, what's your plan? Just what's your alternative? Just make sure that whatever you're doing is also really, really good. If you're just going to double down on lifestyle, then really double down on lifestyle. So
and hopefully
just have a plan.
Hopefully
you just go through life, just floating on the waves and letting the current take you. Eventually the current will take you to me in Trauma Bay
in the ER
with your STEMIs. That's where the river flows eventually. So I'd rather not see you there.
Well, man, thanks again for coming now for our third podcast.
Yeah, my pleasure.
Where can people find you? If people want to get more, where can they go for you?
Sure. Yeah, I've got a little YouTube channel that people can look at some of my content on there. And then I run my private practice and consulting business through manmedicine.com. Just check it out. You can shoot me a message from there. I've got an Instagram account, which I neglect pretty badly, but I'm trying to do better.
Still my favorite YouTube channel. I probably watch all your videos the day they post. So, I mean, you're killing it. And feel honored you coming on. So thanks for your time.
Anytime.
Come and hanging out with us.
Yeah.
Yeah.
Yeah,
It's good.
it's cool. Good to meet you, Coulter.
Yeah, meet you virtually.
That's right.
All right. Thanks again.
I'm gonna go take my folate.
Yeah.
I'm gonna go take my 600 of testosterone.
There you go.
Yeah.